Good evening, sir. Today's case is the name of the XYZ 85-year-old male patient, retired VLI steel plant employee by profession, resident of VLI. Date of admission was 2nd of February and examined on the 6th. Informant is patient himself and his son, which is reliable.
Okay,
Patient
if I may
present.
interrupt, he's just an employee, he's a steel plant. What does he do exactly?
Sir, actually, in the personal history I have described, he is the retired
Go ahead, go ahead,
employee from the
go ahead.
VLI steel plant.
Okay.
Sir, he presented with shortness of breath for the last 7 days, palpitation for the last 10 days, and decreased food intake and weight loss for last 6 months. At the history of present illness, patient was apparently well 3 years back. Then he gradually developed loosening of the weight, as evidenced by loosening of the shirts and pants, and as well as decreased in food intake for the same duration. As per his family member, he used to take 8 chapatis per day, but it reduced to 3 per day as of now, and breakdown of health as noticed by the family member. Patient also told that he was 78 kilos previously 8 months back when he measured at home, but now he is only 58 kg. Weight loss is not associated with an varying range of temperature or low grade of fever or cough or blood mixed put. Patient also had a history of shortness of breath on exertion for last 6 months, which was insidious in onset and gradually progressive in nature. As evidenced by the patient was able to go to the nearby shop within 1 kilometer of distance without any difficulty, but at first, gradually the breathing difficulty increases, and now patient is having breathing difficulty even going to the washroom. Since last 7 days, he developed breathing difficulty even in the day-to-day life activity. Shortness of breath is aggravated on exertion and on lying down over the right side of the body, and relieved on sitting position and in left lateral position. There was no history of any paroxysmal nocturnal dyspnea, or any dyspnea was initially MMRC grade 1, then now progressed to MMRC grade 4 over a period of last 6 months. Breathing difficulty associated with the chest pain for last 3 months, which was insidious in onset and dull aching localized to the right lower region, axillary region of the chest, on relief on lying down over the right lateral position, not radiating and not associated with any cough, sneezing, or radiation. Patient had also complaining of palpitation for last 3 years, on and off, aggravated since last 10 days, insidious in onset and irregular in nature, aggravated on exertion and associated with fatigue and post-palpitational diuresis, not associated with any chest pain or decreased on taking rest. Patient also had history of fluid removal from the right side of the chest, and drain was placed for 21 days 1 year back in 2 times. Approximately 2 liters of fluid removed in single time, and patient had history of hospitalization for 3 to 4 times for the palpitation. There was no history of any abdominal distension, pedal swelling, altered bowel habit, or any lump or swelling in the neck or neck vein engorgement or fullness. No history of any reduced urine output. There was no history of any bone pain, back pain, or any seizure or focal neurological deficit. There was no history of any early morning headache, hoarseness of voice, and audible breath sound. No history of any difficulty in swallowing or regurgitation or vomiting, and seasonal variation of the above symptom was not there. And going to the past history, patient is there is no history of diabetes, mellitus, and hypertension and hypothyroidism or hyperthyroidism. Patient had history of some heart disease, irregular in pulse, and taking medicine regularly. No past history of any tuberculosis or TB contact. No history of any chronic lung disease. On immunization history, patient is vaccinated with both doses of Covishield in 6 months back. No other vaccination in the last 2 to 3 years. On personal history, patient is diet is mixed, appetite is reduced, and sleep is disturbed. Bowel and bladder habits normal and regular. Patient was chronic cigarette smoker, 20 pack year, and quit smoking since last 3 years. No, patient is non-ethanolic and non-tobacco chewer. patient belong to lower socioeconomic status according to modified Kupusami scale, and patient is retired BSP employee of the village steel plant. He was doing clerical job during his working days. On family history, there is no family history of tuberculosis or any carcinoma in the family. He has 5 children. No such similar kind of illness in his family. Uh, History is
Okay, good that you have taken a good elaborative detailed history. Can we go back symptom wise?
yes,
Go to your first symptom, and can you elaborate? Can you analyze what is happening to him?
sir.
The first symptom is shortness of breath, right? Which
Yes,
you
sir.
started 3 years back.
3 years back.
Okay.
Actually, patient, no, sir. Actually, patient first developed the loosening of the weight for last 3 years
Okay,
and
fine.
shortness of breath for last 6 months.
Okay.
Uh, in
And then,
chronological order, sir,
so
3 years.
do you feel this is significant loss of weight?
Yes, sir. It is the in last 6 months there is more than 10% or 10 pounds body weight or 5% body weight reduction in the last 6 months is significant. So it
Okay.
is decrease in the at most 20 kilos in
Oh,
last.
no. Tell you the reason. I updated the.
Yeah, you. This is significant loss of weight, right? Which is also associated with loss of appetite. Correct? Hello, Dr. Kamal.
Yes, sir. I can't hear you properly.
So can you hear me now?
Yes, sir. Yes.
Yeah. So there is the past 3 years there is significant loss of weight, and then next complaint.
Next complaint is the breathing difficulty or shortness of breath for last
Mhm.
6 months, which is
Mhm.
aggravated for last 7 days. And
Mhm.
first was in MMRC grade 1, and on the day of examination it was MMRC grade 4.
Yeah, this we got to know. Analyze why is this shortness of breath happening? Is this related to respiratory system? Is it related to cardiovascular system, or is it related to hematological system? Which system is involved? Do you feel?
Yes,
So you have taken a
Sir,
detailed history, right? Now you have to analyze your symptom and categorize it to one particular symptom. If not, at least two symptoms.
yes,
What do you think is wrong with your patient?
sir. Patient is first developed difficulty in breathing for last 6 months, which was insidious in onset and gradually progressive. Patient can able
Mhm.
to go without any difficulty for in nearby market. So, and there was no history of any chest pain leading to the back or and
I
the breathing
request
difficulty.
all other participants to kindly mute. Hello.
Yes, sir. I can.
Okay, fine.
yes, sir.
Okay.
I've muted others, all the other participants.
Okay, fine, fine. Now, Dr. Kamal, you have elaborated it very well. I'm just asking you, where do you think is a problem? I'm asking you to localize it to particular symptoms. See, dyspnea can occur due to
It's a
cardiovascular
question.
causes and respiratory causes, and significant anemia can also cause shortness of breath, right?
Yes, yes, sir.
What do you think is going on? Okay, I'll make it specific to you. Which system is involved? Which system is causing shortness of breath? According
Sir,
to your analysis, this is based on history.
yes, sir. Based on history, is most probably there is involvement of the respiratory system or cardiovascular system involvement. But
Okay.
on further history, that he had also given the history of orthopnea was there. There is history
Mhm.
of also trepapnea, and
Very
on the
good.
and the patient's breathing difficulty decrease on the right lateral position. So in the
Mhm.
positional variation of the dyspnea is more likely go with the respiratory system. So
Very
respiratory
good.
system is more likely going to affected in this patient.
Okay, correct. And if this patient were to have a PND, PND would have been a more specific symptom of cardiovascular system, right?
Yes, sir. There is no
Even
history of
respiratory
PND.
failure can cause orthopnea. You said he has worsened over 7 days. So acute worsening of respiratory system in case of respiratory failure can cause orthopnea in certain group of patients. Okay, so orthopnea is not specific to any system. It can
Yes,
happen even in respiratory and cardiovascular, but PND more is more specific to cardiovascular system. Okay. And
Yes.
you have mentioned MMRC also, that indicates that you have analyzed it to be a respiratory system
Respiratory.
etiology. Okay.
Yes.
What do you think is the cause of your patient? What are the causes of right-sided tripapnea? As you said, your patient has right-sided tripapnea, right?
Yes, sir.
This
Uh,
indicates that there is unilateral pathology than bilateral. Okay.
yes, sir.
Okay. What are the common causes of right-sided tripapnea?
That isolated trypopnea most commonly if there is unilateral pleural effusion or any mass lesion or any trauma over the chest. Uh, answer most commonly pleural effusion, right-sided pleural effusion can cause the right-sided trypopnea, and then the mass lesion which can cause collapse or fibrosis of the lung, which can produce the right-sided trypopnea.
Okay. Can the other side pleural effusion can also cause the opposite side tripapnea? Let's say patient has massive pleural effusion on the left side. The
Yes, sir.
patient prefers to stay on the left side or the right side.
Left side.
Left side. If even if it is massive, are you sure?
Sir, if the lung is required to expand during when the patient symptom is relieved. So patient
Yeah.
when the patient is lying on the left side, so the
Mhm.
right lung is able to get expand, so the symptom
Mhm.
get relieved.
Okay. So analyzing, summarizing what you have told. See, right, this ipsilateral collapse
Yes, sir.
and mild to moderate pleural effusion ipsilaterally, the patient prefers to lie, will have symptoms on the same side. Okay. But
Yes, sir.
whereas a contralateral huge pleural effusion
Yes,
will
sir.
have mechanical symptoms, will have mechanical pressures over the other side of the lung, and it can cause VQ mismatch also.
Okay.
You get the point?
Yes,
So
sir.
the huge effusion on the left side, the patient prefers to lie on the same side, not on the opposite side. But if it is mild to moderate, which is causing underlying collapse, the patient will prefer to the same side. Okay.
Okay.
Okay. What do you think about the chest pain? Next symptom. Where is the chest pain arising from?
Uh, Sir, as the chest pain is localized to the right side of the chest, and there is no
Mm-hmm.
radiation of the no radiation, and
Mm-hmm.
so the chest pain may be due to the respiratory cause, maybe due to the pleural cause, or maybe due to the parenchymal cause.
Okay. Any chest pain, first you have to see if it is anginal or non-anginal. Do you think this is angina?
No, sir, there is not angina. There is no
Why do
history
you
of
think so? Why do you think so? It is
because
not anginal.
there is no history of chest pain which was there is absolute radiation and relief on taking on the race. Uh,
Hmm. Yeah,
the
this
patient
is
there is
something which is unusual in cases of angina, right?
yes.
Okay. So, in non-anginal causes, what do you think is the most likely etiology, or where do you localize the chest pain to?
Sir, as the patient have the localized to the right lower region of the axillary region of the chest and relieved
Mm-hmm.
on getting on the over the lying down on the right lateral position,
Mm-hmm.
and there is so maybe due to the pathology, maybe due in the right pleura, which can cause the chest pain, and
Mm-hmm.
or the underlying lung parenchyma, which causing compression over the pleura.
Okay. Your explanation was almost right, but there is one point against pleural involvement. What is that?
Sir, pleural
The
involvement
character of the pain
is
is dull aching. Do you think pleura will
no,
have dull aching kind
no,
of
sir.
pain?
In pleuritic pain, there is will be stabbing, catchy pain,
Yeah,
and
exactly.
occurring with the deep breathing or coughing. Uh,
Correct.
so this is against the pleuritic system.
Against pleuritic pain. Okay, I say this chest pain is coming from musculoskeletal region of the chest wall. What is point favoring and not favoring?
Sir, favoring point is the patient is the chest pain relieved on the compressing over the same side. So
Very good.
compression is relieving factor in case of musculoskeletal involvement.
Do you think compression will relieve pain or increase pain?
Uh, Sir, mild compression can relieve pain and
Okay. See, this is one factor which can differentiate pleuritic pain and musculoskeletal pain. Sometimes musculoskeletal pain can be sharp stabbing in nature. Sometimes, okay. But in cases of lung pathology extending to pleura, it might not be. Now, how do you differentiate musculoskeletal pain and pleuritic pain? Is based on the history of which side do you prefer to lie, or which what happens when you compress the area of pain. Okay, so your patient is saying there is right sided chest wall lower side pain which is relieved on lying to same side, है ना?
Yes, sir.
So it is relieved on lying to same side. What happens when we lie to same side? If it is pleuritic, the pleura will be moving as a little less as it were to be on opposite side, right? The same
Yes,
side
sir.
moves less, so there is less of movement. So pleuritic pain would be less on lying to the same side. But any musculoskeletal pain will have tenderness. When you press on that area, the pain increases. Haven't you experienced this?
Yes, yes, sir.
Yes. So this is one point which cannot absolutely tell, but this point favors pleuritic versus musculoskeletal. Okay. You got the point? Should I repeat?
Yes, sir. No, got the point.
Okay, fine. Next symptom.
The next symptom is palpitation. Patient
Okay.
weight loss, shortness of breath, chest pain, and palpitation.
Okay.
In palpitation, patient has a history of compilation of palpitation for last 3 years,
Mm-hmm.
and he has a history of recurrent admission due to palpitation in the last 3 years.
Mm-hmm.
And palpitation is as the told by the patient by the tapping method that there is irregular in nature, and
Mm-hmm.
when he was doing any exertion, the palpitation increases.
Okay, don't repeat. I got to know. We all got to know what was the detailed explanation. We this is what you do when you are supposed to take history and sit before you go before an examiner. You need to analyze things, right?
Okay.
Okay, I'm just asking you what is the cause for palpitation.
Sir, the cause of the palpitation may be due to any cardiovascular cause, which was
Mm-hmm.
any underlying disease that is slow growing process, and for the last 3 years he developed.
Okay, you said in the past history that he is a known case of some heart disease, right?
Yes, sir.
Okay.
As per the patient is not able to tell the which heart disease he was suffering from, but he was taking some medication for the irregular pulse.
Okay. What do you think is the problem?
Sir, it may be due to the atrial fibrillation, which may cause
Mhm.
this kind of problem.
Okay. Why do you think your patient has post palpitation diuresis?
Sir, after any atrial fibrillation, there is when the palpitation subsided, naturally there is
Mhm.
release of atrial natriuretic factor that cause the
Mhm.
diuresis of the post palpitation.
Okay. So you think your patient has palpitations due to atrial fibrillation, right?
Yes, sir.
Right. Was he prescribed something? Did he approach a doctor for anything? Any of these?
Yes, sir. I mentioned he was taking medicine
Mm-hmm.
nearby hospital and
Mm-hmm.
taking regular medication, this homeopathic
Okay.
medication, not consulted
Okay.
any medical college or nearby allopathic medical.
Do you think your patient can also have some valvular heart disease?
Uh, yes, sir. Valvular heart disease also can cause palpitation, but
Mm-hmm.
there should be breathing difficulty, which or shortness of breath, any volume overload status can be there, which can determine whether the valvular disease or not. But patient is on examination, patient have not any volume overload status. By the history, there is the shortness of breath also not explaining the cardiovascular cause. So
Mm-hmm.
it's less likely due to the valvular cause pathology.
Okay. Do you feel that it is less likely?
Yes, sir.
Mhm. This patient also has dyspnea, right?
Dyspnea is
This
there.
patient also has chest pain. All chest pain, cardiovascular chest pain typically need not be anginal.
Yes, sir. Definitely.
Okay, even if you feel it is less likely, which of the valvular heart disease is most likely to explain this kind of palpitation? Do you think, based on history, assuming his age, 6 months duration of dyspnea, 3 years duration of palpitation? the age of presentation.
The palpitation is more commonly in any volume overload status, that is regurgitation lesion.
Okay.
So maybe a patient suffering from any mitral regurgitation can be most commonly in this patient. Maybe there.
Okay. Okay. See, the biggest differential point here is regular and irregular onset of the arrhythmia. You said it was irregular, right?
Irregular also. Yes.
So most likely, most of the cases in irregular palpitations, it will be arrhythmia related.
Yes.
If the palpitations are exertional and regular, it might be, as you said, volume related or regurgitation valvular heart disease, right?
Yes.
So I expected a point answer from you that this is irregular. So I feel it is most likely a
Non-valvular.
non-valvular, or it might be a arrhythmia kind of palpitation. Okay. What do you infer from post palpitation diuresis? Does it happen in all kinds of arrhythmia?
No, sir. In VTVF, it can occur the post palpitational diuresis.
No, I am asking you, why did you ask for it? Does it help in localizing the palpitations or localizing something in the heart? No?
Usually, post-palpitational diuresis syncope usually is seen in paroxysmal arrhythmias, sir. Usually, it will be in mostly supraventricular arrhythmias then ventricular, since they develop some hemodynamic compromise if they are ventricular.
Yeah,
So
good. This is what I expected. This is a nature of supraventricular arrhythmias. Okay, atrial arrhythmias, and which is paroxysmal. A chronic AF will not cause this. A paroxysmal AF can cause this, or a SVT can cause this. Okay.
Yes.
So this is the significance of asking post palpitation diuresis. If this is there, then it is most likely to be a supraventricular arrhythmia. Okay.
Yes.
Good that you have elaborated so much. You should analyze also. Okay. So each symptom, this history will give us maximum points in analyzing the etiology. Now we'll go to a negative history. You also said there is right-sided pleural effusion, right? Right-sided pleural tap.
In the history of in the course of history, he has history of removing the fluid from the right side. Yes.
1 year back.
1 year back, in the course of 1 year, twice.
Okay, in the 1 year back, in the course of 1 year from now, he has twice. It has removed twice. Okay. One thing you are sure of now is right-sided pleural effusion, right?
Yes, sir.
Okay. He has also have symptoms on the right side only. Correct?
Right side only and right side pleural effusion. Yes.
Okay, fine. Okay. Now explain why have you taken all the negative history? Explain your French too. You have taken a good negative history, but we need to know why you have taken.
Yes, sir. First of all, there is patient having the breathing difficulty and chest pain. So, as to ruling out the cardiovascular cause, is there any volume overload status or the right heart failure? So there is no pedal swelling or any abdominal distension. Can any GI system involvement like ascites can cause also abdominal distension and breathing difficulty. In cardiovascular cause can cause pedal swelling and also breathing difficulty, and altered bowel habit that is associated with the cirrhosis or GI illness, and any lump or swelling is on the neck or neck vein is also suggestive of any cardiovascular or any right heart compromisation can cause the neck vein engorgement or fullness, or so there is no history of reduced urine outputs also can also it is related to the any renal system. There is no history of any urine decreased urine output, so it is not related. The dyspnea is not related to the chronic kidney disease or something.
Okay. Why did you ask for lump or swelling? What were you thinking about when you asked lump or history of lump or swelling?
Sir, any lump or swelling in the chronic process, sir, in any lymphadenopathy is there or not? The patient felt any lump or swelling over the neck or groin.
No, what are you thinking about? Yeah, I understood that you were asking about lymphadenopathy, but what were you thinking? Which is the cause of lymphadenopathy? What cause of lymphadenopathy?
So maybe due to the underlying chronic cause, maybe due to the malignancy.
Okay, fine. You were thinking about malignancy when you asked about lump or swelling. Okay. And bone pain, back pain, seizure? Focal neurological deficit.
Bone pain is related to the also related to the hematological malignancy, as the anemia also can cause the breathing difficulty and dyspnea as the patient symptom arises. So any chronic malignancy to the can cause the bone pain like multiple
Okay, fine.
myeloma
Bone
as
meds. Malignancy, same thing. Malignancy. Back pain, the same thing.
same thing.
Malignancy. Seizures and focal neurological deficit. Why did you ask?
Sir,
Brain meds.
yes, sir. Oh, malignancy.
Malignancy, same. Okay. No history of early morning headache. Why? Hoarseness of voice, audible breath sound.
Sir, it is also is a malignancy of hoarseness of voice can compress the RLN, decal laryngeal nerve. Any mediastinal tumor can compress the RLN that can cause the hoarseness of voice, or any laryngeal involvement or laryngeal tuberculosis can cause the hoarseness of voice or altered breathing sound. So we are for excluding the any chronic illness like TB or malignancy. I asked this.
Okay. Next. Difficulty in swallowing and regurgitation or vomiting. Why did you ask vomiting?
In the swallowing and regurgitation, there's also any mediastinal mass can compress the esophagus that can cause to in swallowing difficulty or regurgitation or vomiting, or any malignancy of GI malignancy can cause also the swallowing difficulty or vomiting. And
Okay,
seasonal variation, I asked, so ruling out in the respiratory cause whether any chronic, any asthma or COPD is relation or seasonal variation is there or not. So patient
do you
is
think these symptoms are due to asthma or COPD?
no, sir.
Right-sided trypopnea, chest pain,
No, sir. I has the any
right-sided
previous
pleural
history of.
effusion in the history.
No, sir. Whether the patient is having the past any history of previously the similar kind of illness in the past and seasonal variation is there or not. So that's why if the patient is having the COPD in the last 5 to 6 years back, so he can tell the when seasonal variation is there.
Okay, okay, right. Next, go to the next slide. Dr. Kamal, go to the next slide.
I think he lost connection with him. 2 minutes, I think he's going back.
Okay. Any input from other participants? What do you think is going on? What etiology might be? Okay, Dr. Kamal is back, I guess.
Sorry, sir, for the technical glitch.
Dr. Kamal?
Yes, sir. Sorry for the
Yeah, we're back. One more history that I think you missed was that you said pleural fluid was tapped. I want to know the color of the pleural fluid.
Sir,
Do you think that asking that will lead you to some diagnosis?
yes, sir. Asking that will always definitely lead me to some diagnosis. If the color is straw colored or any hemorrhagic is there, so it is more likely go with the any malignant pathology, or any purulent is there infective pathology, or a clear light yellow can cause any transurative pathology like CCF or something.
Yeah, it is a good habit to ask the color of the pleural fluid, right? It tell us about the etiology and the quantity too. What was the quantity of this patient which was tapped? Did you mention? I don't know. I'm sorry, I might have missed.
Which kind? What's it?
The quantity of pleural fluid which was tapped. And the color.
Quantity,
Color, I don't think so it was mentioned, but did I miss the quantity?
is a 2 liter of fluid removed
2 liters.
twice in
Okay.
the
2 liters each time?
2 liters each time, sir.
Okay, fine.
Approximately, the patient could not actually what is actual
Do you think 2 liters should be removed? Is it the right method or not the right way to go about pleural effusion?
what is it?
Do you think in a single time 2 liters of fluid can be removed from the pleural cavity?
No, sir. Actually, it can cause the reactionary pulmonary edema. So
What
it can lead to
reactionary?
the
It is not reactionary. It is called re-expansion pulmonary edema.
okay, sir.
Okay.
Re-expansion.
So re-expansion, because this stays for a long time and suddenly you evacuate, the lungs try to expand and there will be rupture of the alveolar membrane, alveolar epithelial and the vascular membrane, which can cause pulmonary edema. Okay.
Okay, sir.
So maximum is about 1.2, maximum is 1,500. 2 liters is too much. Okay. Fine. Now go to the next slide. Go. I think we are late. Are we on time, Dr. Balaji? Should I go fast? Because I thought history was important.
Yes, sir. We are on time, sir. We can take the discussion slowly. No problem.
Okay, fine. Okay. Now we know there is some heart disease. Okay. Taking medicine. What kind of medicine we don't know. Is he taking any blood thinners?
No, sir. Actually he was taking the medicine from the side by homeopathic medicine, not in the modern medicine. So
Okay, fine.
it is
Okay. So we don't know about it, right? Okay.
yes,
Okay. Now can you tell us what could be the reason? Now we have identified, I analyzed the symptom to specific system. What system overall do you think is involving here?
as
Or
per
it
the
is mixed?
as per the history,
Mm-hmm.
as per the history, the most probably the symptom involved in the predominantly the respiratory system and the
Mm-hmm.
underlying any cardiovascular system. As
Yeah. So I also feel the same thing because he has underlying some heart arrhythmic problem, which is cardiac related, and over that he has some respiratory issues. Correct?
yes, sir.
So this is what is my analysis too. But clubbing, can you club both of them together? Can any respiratory disease cause arrhythmia in the heart?
Yes, sir. If there is any pulmonary arterial hypertension or ILD can cause pulmonary arterial hypertension, it can lead to
Mhm.
the arrhythmia.
Mhm. Okay. Anything else?
And core pulmonary can cause also. It's not arrhythmia will not be there.
Correct. Correct. This is what I was trying to tell you. Something which is running chronically, but symptoms of palpitation is first, right, in your patient. It
Yes, sir.
started with loss of appetite, loss of weight, and palpitations, and then progressed to have dyspnea, chest pain, and right-sided pleural effusion. Correct.
Yes, sir.
The chronology is little odd, but some of the chronic respiratory diseases can add stress on the right ventricle, right? Pulmonary
Yes.
arteries and the right ventricle, which can cause carpulmonary, which is a known cause of arrhythmia.
Okay, sir.
RA-RV can get dilated. And many of the respiratory infections, not in this case, but otherwise chronic infections, acute infections can cause supraventricular tachycardia. That is one more reason why respiratory etiologies patient can have cardiac arrhythmia. Okay.
Okay.
If
Okay,
you
sir.
want to club both together. Now I want to ask you, what do you think is happening? Now we have localized it to the particular system. Let's leave the palpitations as of now. Let's consider the respiratory system.
Yes, sir.
What is the etiology? What do you make of the etiological diagnosis based on the history? What do you think is happening? Because most of the history was concerned with malignancy.
Yeah. Yes, sir. Actually,
Correct?
most of the history is towards the malignancy. So
Yeah. Do
etiology.
you want to keep any differentials
Yes,
other
sir.
than malignancy to explain your symptoms?
Yes, sir. As per the history, as a disease is a chronic process, there is some history is suggestive of any malignancy. So the first degree will be malignancy of the right side of the lung or any adventitial tissue. or secondary will be the, as of the most common infection in the India that can cause mimic the malignancy is tuberculosis. And the third, as per the patient has history of any occupational exposure, so occupational exposure can lead to the cause same kind of illness.
What occupational exposure he has? You said he was a clerical employee.
Clerical employee, but he is working in the steel plant, so that can lead to the asbestosis or silicosis that can lead predispose to the malignancy.
Okay, so I would suggest all of you, if you consider any occupational lung disease in your differentials, please elaborate the occupational history. I want to know how much he was exposed exactly to the metal area or the places where the exact alloy making is situated, or his personal protective equipment. Was he given personal protective equipment like respirators during his work, or was he assessed frequently by doctors, and how long he has worked? All these are very important, and the onset of symptoms with respect to his job. Okay, all of these should be elaborated. If you have to keep, now you have kept a occupational lung disease as a differential, right?
Yes, sir.
So many of the occupational lung disease can expose a patient to carcinogens. Many of the chemicals are known carcinogens of the lung, liver, and GI tracts, right? So you have to ask in detail. Okay. Okay. What do you think in your patient is unlikely to be a malignancy? Everything is favoring a malignancy etiology, but one thing which is against it.
Sir, there is no lymphadenopathy is there.
No, we have not examined. Na patient can miss swellings. You said respiratory system is involved. Okay, let's consider lung malignancy. How many patients of lung malignancy do you see with lymph nodes? It is not that common, right?
Sir, one thing is there is no cough is there in the patient. Cough.
No cough is there. So do you think cough will be there in all the patients?
Cough or expectorant sputum can be a common symptom for any chronic illness like malignancy.
Okay, okay. Dr. Kamal, I'm asking you what is there which is not fitting in the diagnosis of malignancy. I'm not asking you what is not there. No, you have certain A, B, C, D, E, F, right? You have to fit into a particular diagnosis, right? So I'm asking you which one of your explanation, which one of your symptoms is not fitting into a diagnosis of malignancy? Generally. Okay. Can I give you a clue?
Yes.
What is the total duration of illness?
Sir, total duration illness is the last 3 years.
3 years, right? Do you think lung malignancy patients
no, sir. Actually,
will have symptoms for so long without treatment?
Sir, he has fluid removal in the last 1 year.
That is from 1 year, right? Okay. Everything explains, but the loss of weight and loss of appetite is going on for 3 years, right?
Yes, sir.
I don't think so. 3 years is a very long time for malignancy, especially lung malignancy when it is so aggressive. Correct?
Okay.
But based on history, it cannot be 100% sure. But there are patients who can survive for 5 years, 6 years. But patients already having systemic symptoms, loss of weight, loss of appetite for the past 3 years, it is little odd that he's having a malignancy, but he can still have. But based general assessment of your history, that is one odd thing which I feel for malignancy. And he has one more risk factor that you have forgotten for malignancy. He's a smoker, right?
He's a smoker. I mentioned in the person.
Correct.
He's a
Okay.
smoker.
Okay. Anything else? Any inputs from other participants, other doctors? Maybe we have missed something. You can add on any other etiology that you want to consider.
Can we still, although we are considering malignancy as the first differential or etiology, can we still consider indolent infections? Because epidemiological, we don't know. So underlying TB or other infections of the lung since we are thinking of respiratory system.
That is our second differentials, right?
Yes, sir. Second.
Any other, apart from TB, can we consider any other organisms? Like
what kind of organism do you want to consider?
Like Brucella and
NTM, non-tuberculous mycobacteria.
NTM. Yes,
Nocardia.
sir. Yes, sir. But because underlying weight loss is also there, maybe there is underlying immunosuppression and pulmonary nocardiosis.
Yeah. Could be possible, but based on history, we can't specifically say one particular microbiological diagnosis, but could be possible. I would be more sure if he had a COPD or existing lung disease and would have called pulmonary nocardiosis. But he doesn't have any existing lung disease or he's not immunocompromised as per history. I can't say it is nocardia, but we have to keep a broad differential. We have to consider NTM and nocardia too, but it is less likely than tuberculosis. TB would be. I have not seen nocardiosis or NTM infections which is causing recurrent pleural effusion, which needs tapping, therapeutic tapping of 2 and 2 liters. Right? Have you seen? I have not seen. But we have seen TB, recurrent unilateral pleural effusion with tuberculosis. Correct? It is possible, but it is less likely. Any other differential etiology wise? Could it be infective endocarditis, subacute? Not for 3 years, right?
Yes.
Can infective endocarditis cause all of these symptoms? It can cause palpitation. There is some existing heart disease.
But there is no history of yes, sir. Palpitation can be there. Dyspnea also can be explained, and chest pain can be explained. But
Chest pain can be seen. Dyspnea can be seen. Fever. That is why we are calling it subacute infective endocarditis. There is loss of weight, loss of appetite. But pleural effusion of this massive size is not explainable with infective endocarditis. Alva. That is a odd point.
Yes, sir.
But pleural effusion of minimal or moderate severity can be seen in infective endocarditis, especially subacute infective endocarditis. But massive pleural effusion is not predominant finding. Correct? Can this be tubercular because we have pleural effusion, the involvement of the heart? Can this be some sort of vasculitis, which is involving the lungs and the heart together? Think broadly. Think all the rarer things too. You'll not miss. The more broader we keep the differentials in history. I'm not telling first as vasculitis. Can this be vasculitis? See, loss of weight, loss of appetite. But 85-year-old male is little unlikely.
Age is little off for vasculitis. Even if you think like ANCA-associated vasculitis, but some other systemic features should be there, like crash, renal involvement.
Involvement, renal involvement, upper respiratory tract. These are not there. Age is little odd. The sex is also little odd. Anything else?
any other rheumatological condition can also not be there apart from the vasculitis. Age is not present.
Correct. Okay. So overall, summarizing the history, we have some smoker, elderly male with constitutional symptoms and right-sided unilateral complaints with history of right-sided pleural effusion tap, right? And some underlying heart disease. Okay, proceed.
Underlying heart disease.
We'll go to the examination, see what can we make out.
Sir, coming to general physical examination, patient is conscious.
Okay. Dr. Kamal, please be specific. Highlight only those things which are abnormal. Okay.
Okay, sir.
I presume you have made a detailed examination, but highlight things which are abnormal and specific negative findings or positive findings.
Okay, sir. Sir, on general physical examination, the decubitus of the patient is lying over the right lateral position. The nutrition is poor, BMI is less, and the pulse is 110 per minute, but is irregular. All peripheral pulses are equally palpable, but the arterial wall is thickened here. And respiratory rate is 20 cycles per minute.
Sorry, I'll interrupt. Go back. Okay, what do you do when you find irregular pulse?
Sir, I have to check for the pulse deficit is there or not.
Yeah, you have not mentioned.
Sir, in the pulse deficit, mentioned in the previous examination.
Okay, mentioned in the CVS examination. Good, good. What are the irregular rhythm that you are aware of? What could be possible? So now we know the pulse, the nature of the pulse. It is irregular. What are the common causes of irregular rhythm? One is atrial fibrillation. Everybody knows that. Other two or other three. Are you aware?
Uh,
Irregular rhythm is only atrial fibrillation or something else?
The other thing is it can be multifocal atrial tachycardia. Other
Good.
thing is we can have multiple atrial or ventricular ectopics. And
Mhm.
any supraventricular arrhythmia with variable conduction block can be irregularly.
Okay, you have covered almost all of them. Okay, you have to keep a differential of these. And how will pulse deficit help in differentiating all of these? If
Uh,
I remember correctly, it is the cutoff is 10, right? I don't know.
10,
I don't
yes,
remember correctly. The
more
cutoff is
than
10,
10,
right?
it's
Yeah.
more than 10 we consider atrial AF, and less than 10 usually ectopics because of that lower rate intrinsic.
So this is basically to differentiate ectopic rhythm from an atrial arrhythmia. Okay, fine. Next,
Atrial
the
flutter
respiration is normal. Now go to the next slide.
The next is positive finding is there is a grade 3 clubbing is there.
Okay, patient has grade 3 clubbing.
Grade 3 clubbing, but there is no cyanosis, no jaundice, no lymphadenopathy, and
What about icterus and pallor?
no pallor and icterus is
No
not there.
icterus. Okay, fine.
But the temporal muscle wasting is there over due to the loss of the weight.
JVP?
JVP not right.
Okay, did you find out A wave? Did you see A wave of JVP?
As the rate is 110 per minute, so
Okay. You couldn't make out. Okay, what do you expect in this patient?
sir, as a
Okay, assume that this patient had a rate of 60 with irregular rhythm. Do you expect a A wave to be present or absent?
so the AF is absent in AF, and AF is present in multiple ectopics can be there.
Good. Correct. Okay, this is what, see, you should not blindly examine. You have to think of what are the expected findings and then examine based on your differentials. Okay, now we have kept a possibility of atrial fibrillation. So you should think that, oh, in A wave, atrial fibrillation, A wave is absent. If you specifically check for A wave, if it is absent, then you will be more happy, right? The point is favoring your diagnosis. Correct? Am I correct?
Yes, sir.
That is how you should go. You should expect things. You should anticipate things. Okay.
Next, sir, positive. The clubbing is there, and
Okay. Good.
on head-to-toe
Favoring what?
examination,
Favoring malignancy, favoring TB, clubbing.
favoring grade 3 clubbing is there, and if favoring any underlying chronic disease, maybe malignancy.
Maybe malignancy. Okay. Not TB.
Sir, TB can cause any lung or pleural any can cause clubbing underlying.
Yeah, you said a very
Can't be differentiated.
yeah, which is more common to cause clubbing. TB is actually not listed as a cause of clubbing. Okay.
Yes, sir,
Very
but any
rarely
infection.
miliary tuberculosis or TB with ARDS can cause clubbing. Okay, that is very rare. So generally speaking, grade 3 clubbing should be favoring more of malignancy than tuberculosis. Okay.
But hypocasis tuberculosis can cause clubbing in infection, but yeah, there is what is rare. So
Yes,
malignancy is more
this
likely.
you have to say. Okay. Temporal, you have commented about temporal muscle wasting too. What does it suggest?
It suggests there is a chronic malnutritional status or due to the weight loss.
Or it is supporting your both of your diagnosis, TB etiology and diagnosis of malignancy, right?
Any underlying chronic etiology can cause muscle wasting, so it can be in both cases.
Okay, fine. Next.
One question out of this for clubbing, should we stick on to lung India grading or should we, because there are multiple sources for that grading? in multiple books. So, which would you suggest, sir? Or which would you?
I'm actually not an examiner of the state. I don't know actually. See, what I want you to know is what is the significance of having clubbing and how do you these gradings and what the examiner asks and particular grading of each society is not relevant to our practice, right? It is just to pass an exam, but you should be knowing it to pass an exam. I think this would be a question where your senior examiners, professors would answer well. I don't know. There is the one grading which I remember is which is given, which is usually followed in most of the colleges. I'm not sure about which grading you should follow, but you should know that grading causes the clubbing causes and the grades. What do you call and how do you do it? Okay.
Yes. Okay.
Okay, I think I'm not answered your question, but I'm not sure about what you will be asked about in your exams. But I want you to know some things for your practice that it
Yes.
is important and grading. You also know that okay, we'll talk something about grading. What is the earliest finger to have the grading features?
Right
If it is
index.
an acute curve, how
Sir,
do
right
you?
index finger, sir. Sir, index
Is
finger.
there any score to measure early clubbing?
Uh, Sir, fluctuation is
Digital
7.5.
index we can use.
Yeah,
Digital index.
how do we calculate that? I think almost all participants can participate. Okay, it is not. It should be a discussion rather than I directing particular questions to Dr. Kamal. Okay, tell me. Go ahead. How do you do this?
We take the ratio of distal phalangeal depth by interphalangeal depth. Ratio of all this, the whole thing, we take that ratio. If it is more than one, if it is equal to one, it doesn't really help us. But if it is more than one, then it is suggestive of a clubbing. If it is less than one, it's not.
What is differential clubbing?
Sir, there is clubbing in the lower limb and upper limb is not there.
Mhm. So these all you shouldn't ask the examiners. You shouldn't make the examiners ask you again. If I were to describe clubbing, I would describe it grade 3, pan digital, unilateral, bilateral, painful, not painful, and the grade. Okay, explain everything if you have a positive finding.
Okay, sir.
Got it? Okay, good.
Sir, on head-to-head examination, there is a male portal baldness and temporal hollowing and no neck gland or supraclavicular gland and grade 3 clubbing in all 4 limbs and nicotine stain in the right hand.
Okay.
On the basis of the general physical examination in the history, I would like to examine the respiratory system first.
Mm-hmm.
So, in the respiratory examination, the upper respiratory tract, there is nostril is normal, no sinus tenderness.
Significant findings, positive findings.
Okay. Uh, Sir, on inspection, there is trachea shifted towards the right side, and apical limbus is shifted towards medially. There is scar mark in the right axillary region, and there is decreased respiratory movement in the lower anterior chest and lower posterior chest wall. And by the palpation, there is also trachea shifted towards the right side, and there is rib crowding noted in the right infra-axillary region. And by the palpation, there is decreased movement in the inframammary region, infraxillary, and
In the right infra. Hello.
Think it's not audible, sir. Connectivity issue.
I don't think so. There is a region called inframammary. Is there?
infra.
No, sir.
Hello, sir. Sorry, sir. Disconnected. No, no
That's
voice.
okay. It's okay. It's okay.
Sir,
Go back 1 second. Palpation. I missed something. I missed the.
sir, the palpation, sir, on the palpation there is decreased movement. On the palpation there is trachea shifted to the right side, and there is decreased movement on the right inferior region of the chest, and rib crowding is there in the right infraxillary region.
Okay,
And
the
on
apical impulse is in normal position.
this apical impulse is shifted towards medially.
Shifted medially. So overall, there is volume loss on the right lower side. Correct.
Like volume
And
loss
upper.
and mediastinal shift is there. So
Mhm.
maybe
Both upper and lower, right?
no, sir. Sir,
You said trachea shifted to the right side.
yes, sir. Trachea shifted to the right side, and also the apical impulse shifted to the medially.
Medially in the sense right side than the normal position. Correct.
Yes, sir.
So there is upper and lower mediastinal shift both.
Upper and
Correct.
lower mediastinal shift both. Yes,
Okay. And there is decreased breath sounds, decreased movements in what all areas?
Decreased movement in the sir mammary, inframammary, infraxillary, and infrascapular region.
I feel there is, I am sure that there is no inframammary area. I think you should all confirm this once. There is supraclavicular, infraclavicular, and mammary on the anterior
Mammary.
side, axillary, infraxillary on the lateral side, and suprascapular, interscapular, infrascapular on the posterior side. These are the standard areas of respiratory examination. Okay, I don't think so. There is inframammary size. I don't know what is the source, but this is a standard source which we used to follow. Okay, fine. And there is reduced movements in what all areas? Mammary, inframammary.
Mammary,
So
infraxillary,
basically,
and
right lower
infrascapular.
and anterior.
Yes, sir. Anterior and lower.
So all the three sides. Okay, fine. Okay, next.
On dimension, there is a decreased expansion of the right hemithorax at the level of the nipple, and there is a decreased there is a decrease in the spino-scapular length, and the spinoacromial length is increased. So which suggests any collapse or fibrosis of the right side.
No, no, we'll not go into the analysis. We'll
Okay, sir.
go. What is the finding now? There is right-sided volume loss, right?
Right-sided volume loss. Yes.
The right hemithorax is smaller than the left hemithorax. Correct.
Right, yes, smaller than the
Which
left hemithorax.
area is it maximum?
Sir?
Which area is it maximum? Spinoscapular is 6 and 7, and spinoacromial is 15 and 13. Okay, fine. Next. I got it.
On the vocal fremitus or resonance, there is a decrease in the same areas where the movement is decreased. That is the mammary, infraxillary, and infrascapular region. And going to the percussion. Hello.
Go ahead, Kamal.
Yes, sir. There is a dull note is noted in the mammary region and the infraxillary region and the infrascapular region. The dull note is noted. So there is no shifting dullness. Tidal percussion is remained, and trabecular space is tympanic. On the auscultation, there is reduced NVVS in the mammary, infraxillary, or infrascapular region, and the vocal resonance also reduced in the same areas where the decreased in the vesicular breath sound. So this is the respiratory system examination.
Okay. Okay, go ahead. We'll complete all the system examination and then we'll discuss.
Okay.
In brief.
The other system is the cardiovascular system. There is first and second heart is hard irregular in the all four areas, and no added sound is there. There is no pulse deficit, and the CNS examination, no focal neurological deficit is there, and parabdominal there is no ergonomically hernial ulcers are free, and there is no parectal examination done. There is no hemorrhage or any nodules seen.
Okay.
Sir,
Tell me. On examination, what did you find? How do you explain? What is the diagnosis?
Sir,
What
on
is
the
your,
examination,
let's commit this way. Most of the examiners ask you the diagnosis. before explanation. Now tell me, commit one particular diagnosis and then we'll go.
Sir,
Discuss.
it is uh, sir, probably due to the respiratory system is involved, and there is volume loss in the right side, in the
Don't
right
explain.
hemithorax.
Give me the diagnosis.
Okay. Right middle
Then
or lower lobe collapse. Query
right
due to
middle and yeah, what? Right middle
and lower lobe
and lower lobe. Okay. Collapse.
collapse due to underlying malignancy or tuberculosis. Patient is not in respiratory failure or cor pulmonary. And in a known case of atrial fibrillation, this is the diagnosis.
Okay. Differentials for collapse. Only you feel it is only collapse. Anything else
Collapse
could
or
be possible?
the collapse or fibrosis may be there.
Collapse or fibrosis. Fibrosis of what? Parenchymal fibrosis or pleural fibrosis?
The parenchymal fibrosis, as there is a mediastinal evidence of the mediastinal shift, and there is a dull note on the auscultation, on the percussion, and decreased air entry over the on auscultation. So probably due to the parenchymal fibrosis.
Parenchymal fibrosis. Okay, what is the main point which indicates parenchymal fibrosis? What should be there? Okay, there is volume loss. Should you hear anything? How would you explain dull sounds without crackles to explain pulmonary fibrosis? Right? That is not usual finding, right? Anything other differential, closed differential, second differential for this?
Second division, sir, right side pleural effusion or mild to moderate effusion can be there, but the effusion with collapse can be there, so it can cause the same.
Effusion with collapse. Okay, but what about shifting dullness?
Sir, in mild to moderate effusion, there might not be shifting dullness.
I would have been happy if you have said me loculated pleural effusion, not mild to moderate. Mild to moderate will also shift, right? If it is free flowing.
Okay.
Okay, so it could be either a loculated effusion. What could be other differential based on your examination findings? Could it be a right fibrothorax?
Yes,
Think.
sir, there.
Then why didn't you say? It is not shifting because he is having repeated pleural taps. There is repeated pleural effusion accumulating, which is called pleural thickening, and there is volume loss due to fibrothorax. Is that possible?
Yes, sir, possible, sir. Because deep crowding is also is there in the right side, so suggest.
The constant pleural pathology is known to cause pleural thickening and fibrosis, correct?
Yes, sir.
If pleural fluid is causing it, there will be more pronounced in the lower lobes than the upper lobes, correct?
Yes, sir.
So fibrothorax can explain all of these.
The fibrothorax, the mediastinal shift cannot be explained with the fibrothorax, I think.
Why? What happens when there is fibrothorax? See, the closed differential with collapse is always fibrothorax. Okay.
Okay.
But this is one odd point for fibrothorax is that you have localized features. There is the more pronounced features are there in the lower areas than the upper areas. Okay, this might be in a situation where there is transition from lower areas to upper areas in that process. Okay, but always when you keep a differential of collapse, fibrothorax is always a second differential. Remember this, and it is it is difficult to clinically differentiate. Only one thing which can differentiate both of these is history, recurrent pleural pathologies, history of pleural taps. But this patient also has that, right?
Okay.
I'm not worried about investigation. Chest X-ray may show anything. It might show pleural effusion only. But based on the findings, we have to keep certain differential. Always keep second differential. Plan B ready. Okay. Okay. Fine.
Yes.
So now you want to keep malignancy higher or TB higher?
Sir, as per the examination, the malignancy should be higher.
Why?
Uh, on the basis of examination, sir.
Yeah, why? Why would you keep malignancy higher than TB? What is the point in an examination that you have had which suggests more of malignancy over TB?
That there is the volume loss is there, and
Volume loss could be seen in both pathologies. Okay, the answer is clubbing. Clubbing favors more malignancy than TB, right?
oh,
That is the only point in an examination which favors malignancy more than TB. Okay, everything else could be explained by both of the etiologies. Okay.
uh, should we go to
Anything
investigation?
else from other doctors, other participants? Come on. Have we missed anything? Any other differentials that you have kept? Ideally, we need to examine CVS detailedly. If it were to be examination, you should have calculated pulse deficit. Okay, you should have auscultated P2 carefully.
Yes.
And you should have you also are expected to mention if the patient has IE features or not, right? I am not sure, but we were expected to. Signs of infective endocarditis. Okay, so all of these in a heart, in a cardiac patients are you need to know. Any inputs from other participants?
Sir, could you tell us, like, based on the examination, how do we determine which lobe is really affected or collapse in case of collapse or fibrosis? What are the points that we should consider to localize? And can the physical examination help in localizing up to the level of the bronchopulmonary segments?
Yeah. So for this, you need to know the surface anatomy of the lungs, surface marking. I think this is the first. This is always be the first description in any clinical method book that will tell you the surface marking of the lung. Okay, I'll just try to tell you with the areas. Okay, if that is possible. So the right upper lobe, we have three lobes on the right: right middle lobe, right upper lobe, right lower lobe, and we have two lobes, that is right left upper lobe, which has upper lobe and lingula, and left lower lobe. Okay, the areas which corresponds to right upper lobe are what? Supraclavicular, infraclavicular areas, and suprascapular areas, and the back. The right middle lobe is part of infraclavicular and mammary area on the front, and the rest of the areas predominantly are occupied by the rest of the right lower lobe is occupied by infrascapular, infraaxillary, part of axillary, and part of interscapular. Okay, this is roughly based on the areas. The same thing holds on to the left side. Ideally, you should know the surface marking of the horizontal fissure and the main fissure, major fissure and minor fissure. That will ideally tell you which lobe of the lung is involved. Okay, so the roughly to tell the minor fissure goes around fourth and fifth rib, fourth rib. Okay, the part above fourth rib would be upper lobe, below that would be middle lobe on the right side. The major fissure, you have a surface marking when the patient is upright and held and holding his arms on his hands on his head. It marks the medial angle of the scapula. It runs that way. This is given in any clinical method book. So the answer to this is know the surface marking, and just based on the areas involved on your examination, you can categorize it to middle lobe, upper lobe, and lower lobe. Okay.
Yes, sir.
Okay. Any other question? Okay, what has happened to the investigation? Let's see the investigation now. Okay, don't go to the investigation. What would be the investigation you want to do, Dr. Kamal, in this
Uh,
patient? First,
Sir, at first,
1, 2, 3. Don't go to non-specific CBC, TLC. I don't want that. Specific investigation. This patient has come to you in OPD. What are the investigations that you want to perform?
sir, at first the chest X-ray,
Yes,
then
good. Okay, show us the chest X-ray.
this one.
Okay. Hmm. Go ahead. Tell us what is there.
Uh,
I assume that you know the normal typical description of the chest X-ray. We'll not go into that. Tell us what is abnormal.
Sir, there is the homogeneous opacity seen in the right lower zone of the lung, probably in the lower zone, and there is the shifting of the trachea towards the right side, and there may be the uh, and there is mild and cardiophrenic and cardiothoracic angle is blunted here, and there is rib crowding over the right side.
Okay. Anything else that you note?
Sir, film is in expiratory film. So
Okay. Just like I think this is AP view also, correct?
is
The rotated film also. And
right.
then any significant finding that you note on the right hemithorax,
Film.
right side?
Sir, right side rib clouding is there, sir.
Okay, fine, accepted. It is there for sure. And there is volume loss on the right side. And
Yes, sir.
anything significant?
Fusion
Okay.
along with
I don't
effusion
have
and
a
consolidation.
pointer, but if you can see the place where the pleura is actually on the right side, very close to the chest wall, just inside the chest wall, there is some opacity running. You go up, go up. Yeah, that area close to chest wall. There, can you see some opacity, which is very close to the wall, chest wall, which is not there on the left side?
Yes, sir.
So in a rotated film, it is ideally should not be commented, but I feel there is some sort of pleural thickening. Pleural thickening opacifies like this with crowded ribs, and there is a opacity which runs along the chest wall on an X-ray. Otherwise, it is not visualized on an X-ray. Can you compare it on the left side? See, there is nothing as of that sort on the left side, but there is
Right.
something on the right side. So let's confirm it on the pleural effusion lateral decubitus view can also be confused in similar to this X-ray, but we need to confirm this on a CT. Okay. Okay, fine. So there is some, this is consistent with our diagnosis, right? Now, what do you feel? Collapse, pleural effusion, fibrothorax? What is the?
Sir, most probably due to the collapse should be the first priority, first differential.
Mhm.
Then then the fibrothorax can be there after that.
Mhm. What kind of collapse is this? Are you suspecting? I don't.
Sir, there is not atelectatic collapse, not compressive collapse.
It's an active or a passive collapse. Or is it okay? You use the right term.
The active collapse are due to the obstruction of the bronchus
Mhm.
from the outside or inside that can cause
Mhm.
the collapse of the right middle or lower lobe.
Okay. Do you think this opacity is consistent with any lobe collapse?
Opacity is more likely in the right middle and lower lobe.
Is it consistent with middle lobe collapse or lower lobe collapse?
Sir, as the film is, hello sir.
Yeah, I am able to hear you, but okay. Okay, fine. Go ahead. I think this might be. Just make a note of all the lower lobe. Just go in Google and search. Try to see the images of unilateral lobe collapses. Okay.
Okay.
right upper lobe collapse, right middle lobe collapse, right lower lobe collapse. Both all specific collapses of each lobe will have typical appearances on an X-ray. We have limitation. This is rotated film AP view. We cannot completely rely on this, but just I'm trying to tell you, this is not consistent with any typical kind of collapse. The middle lobe will not be this way, and the lower lobe will have a pyramidal shaped opacity. The apex should be pointing towards the hilum. This is the opposite side. The apex in this triangular opacity is pointing towards the chest wall, right? So for me, it doesn't fit any collapse, but it might be subsegmental collapses too. Okay, fine. Let's go ahead. We'll confirm it on what investigation you want next.
CT thorax can be done.
CT thorax. What kind of CT thorax? You have
Sir,
to be specific. You should be asking your radiologist to be specific. He'll ask you. He'll make a phone call to you asking, Dr. Saab, what kind of CT can I perform?
Sir, both contrast and not contrast. In non-contrast, HRCT can be done, and CECT also can be done.
No, I'm just asking you what you want in your patient. In this patient,
CECT thorax.
you want to perform a CCT thorax. Okay.
Yes.
Anything else? Only thorax?
With the abdomen, we can take since we're suspecting.
Primary bleeding out.
Okay, good. So when you are suspecting lung malignancy, always remember you have to include adrenals. Okay, so upper abdomen should always be included. Most of the CT radiologists will acquire until upper abdomen without saying, but if you mention that indicates to the examiner that you know any malignancy in your differential diagnosis, include CCT thorax with upper abdomen. Why upper abdomen? Because the metastasis, you have to include the adrenals. Okay. And the liver of course will come if you screen for adrenals. Got it?
Yes.
Okay, I would write on the requisition form CECT thorax with the HR reconstructed film to include upper abdomen. Okay. Okay. Show us.
One question, if I can interrupt, sir. Like, is this going to be any lymph node here that we are seeing? Pointer visible, sir?
Yeah, I can see, but as I said, this is AP view and a rotated view.
Okay,
so exact this thing cannot be actually visualized on this or commented upon this. It looks like a globular opacity. It could be.
Okay. And this morphology that is there, sir, here, like it's not a smooth, like irregular morphology here.
Exactly. That is why
Is
I
that
say
the pleural?
it will not collapse.
Okay, sir.
And this morphology is more consistent with the irregular margin, goes more in favor of consolidation than collapse. Collapse will always be smooth. Will have smooth margins.
Okay.
Okay, and the collapse apex will always be towards the hilum, as expected. You know why, right? Because there is pathology in the hilum or in the airway which makes the lung collapse in an active collapse.
Sir,
Okay, so I also expect some sort of pleural effusion. Why? Because the angle is not seen. There might be some opacity with the pleural effusion also contributing to the opacity.
yes.
Okay.
Sir, didn't get you the what is the cause of the apex towards the
See, all the bronchovascular segments of the lungs are made in that way that the hilum is the main entry or exits of the airway or the vessels, right? You know this, right?
yes, sir.
So the main point where the branches of the airways or the branches of the vessel divide is centered along the hilum. So in case of active collapse, as you said, the main problem is in the airways, which can make the aeration of the lungs not possible, so the collapse. Okay, so if there is problem proximally in proximal airways, distal airways also collapse. So the point where it supplies is huge from one point. You get my point?
Yes, sir.
So from one particular point in the hilum, all the supply to one particular segment or one particular lobe starts. If there is a lobar collapse, so that compresses. So the triangle base is towards either towards the chest wall or towards the diaphragm, and the apex is either is always towards the hilum. This I am speaking in terms of lobar collapse, but it can be altered in terms of subsegmental collapse or segmental collapse. But it still will follow the same rule. It will be towards hilum than away from the hilum. Okay.
Okay. Thank you.
I said this is right-sided lower lobe mass. Am I right or wrong? With this chest X-ray.
The mass should be then homogeneous opacity. There is some inhomogeneous opacity in between.
Okay. Any other strong point against mass? Okay. This is a reason, but this is not very strong reason. Some of the masses malignancy can be irregular.
Okay.
What is a strong point which is against a mass?
Margin, sir. Margin.
No.
Same side shift and upper lobe involvement, rib crowding and upper lobe trachea shifted to the same side.
So overall,
It's like
there
lower
is
lobe
volume loss.
loss.
Volume loss will not be seen in a mass patient. Okay. If a patient has mass, you always need to have volume gain. Volume gain as in mediastinal shift to opposite side, contralateral mediastinal shift. You said there is rib crowding, correct?
Yes, sir.
You don't expect rib crowding in a mass patient. A mass patient will have volume gain. And if this were to be a mass, I would expect the trachea and the heart to be shifted towards the opposite, not the same side. Okay. For me, this X-ray is consistent with fibrothorax with some pleural effusion and probably some mass down there which we can't see, because that thickening of the pleura is striking very much to me. Okay, there might be some underlying collapse also. Okay, fine. Because I feel you see this X-ray, there is significant volume loss on the right side than the left side. Okay, fine. Next, go ahead. Show me the CT scan. First, show me the mediastinal window. Okay.
Sir,
Video, sir.
before we move on to CT scan, sir, could this be a long-standing right-sided pleural tuberculosis with a lung entrapment?
Long-standing, come again?
Vijay, sir, let
This
me.
is a long-standing right-side pleural effusion of tuberculous origin with the lung entrapment.
Lung entrapment.
Yes, sir. Because of that visceral pleural fibrosis. So that could explain the collapse features as well, the localized collapse features as well at the lower zone, since the dependent portion for the pleural effusion.
This is what we are speaking, right? You have changed the terminologies.
No, sir. Fibrothorax is that like the narrowing of the interspaces due to the parietal pleural thickening. What I was thinking, visceral pleural fibrosis could have been the cause for the passive collapse.
Come again, visceral pleural fibrosis?
Visceral pleural fibrosis due to the repeated inflammation.
Correct.
Not the compressive collapse I'm talking about, but because of the restrictive lung expansion due to the visceral pleural fibrosis leading to the entrapped lung.
Okay, okay, that is a possibility, but how do you explain?
Yes,
How do you explain visceral pleural inflammation due to tubercular origin?
Yes, sir.
Was
Tubercular
or differential?
improperly managed. Could have been further evaluated, sir. Like for the other investigations,
you
like
say
the history part.
Opacity is due to residual pleural effusion and the visceral pleural thickening and unexpanded lung is what
Yes,
you're
sir.
trying to say, right?
Yes, sir. Yes, sir.
That could be also a possibility, but that is a radiological possibility.
Okay, sir.
So that cannot be a clinical possibility, right?
Clinical possibility, yes, sir.
This you could explain this once you see the visceral pleural thickening based on radiology.
Yes, sir.
Correct? Okay.
Yes, sir.
Is this Chetan?
Yes, sir. Chetan, sir.
Okay. I somehow recognize your voice. Okay, go ahead, Dr. Kamal. Contrast, non-contrast.
Non-contrast.
Okay. Show us the axial videos first. Can you show us the axial images first?
Axial is not in the film. It is not in photo.
Okay, show us the film. You can see whatever sagittal coronal images, but I am comfortable with axial images because CT images predominantly give axial images. Show us the uppercuts. Okay, fine. Okay, tell me, explain the findings, whatever you see. It is not very clear, but okay, you have seen it more clearly. So can you explain what is that? Only significant finding. When was this X-ray and CT scan done? Both at the same time? What is the date difference?
No, sir. X-ray on the admission, the CT done the 3 days after.
So CT was done 3 days after the X-ray, right? Okay.
Yes.
Okay, what can you see? Go ahead.
There is effusion is there in the both sides. Pleural
Both
effusion is
sides.
there.
Correct. And any pericardial effusion? No, it doesn't look like. Okay. Now, Dr. Chetan said something. Visceral pleural thickening. Is that there?
Visceral pleural.
Sir,
See here also you can visualize the volume loss. See the look at the
yes, sir.
ribs on the right
Yes,
side
sir.
as well as the left side. You can obviously see there is rib
Yes, sir.
crowding.
Pleural
Right?
enhancement is there on the right side, like a pleural rind, as you see in the empyema.
Ideally, we should have a contrast enhanced images. Do we have a
Yes, sir.
contrast enhanced image of mediastinal cuts? Yeah, perfect. Now, what is going on? See, there is almost bilateral moderate kind of effusion. There is bilateral. Okay. And what about heart shadow? Is it appearing normal?
Normal.
Normal. Comment about the right heart chambers. Show me where is RA and RV. Contrast. Go to contrast. Right atrium, right ventricle. Explain, Dr. Kamal. Go ahead.
The
Tell us
heart
what you
shadow
said. Pleural effusion. Anything else?
number one palpitation. Second is the volume loss, and there is
Volume loss is there. Correct.
collapse. Margin of the lung. The heart is look normal to me, sir.
Okay. Okay, fine. Actually, this depends on the scale of the CT scan. I'm not sure. If to me it feels that RA and RV are mildly dilated. I don't know. The lowermost images which you are showing, I don't know. It has to be reconfirmed once again on the scale. Okay, fine. When compared to LV, I feel RA is little dilated.
Yes.
LV, RV is comparatively bigger. No, I'm not sure. Okay. What is happening to the right lung? Right lower lobe? Where is your pathology?
Sir, in any there is bronchial cutoff sign is there, so maybe any lesion can compress the right.
Show us where is bronchial cutoff. Trace the trachea until the carina and the further divisions. I think we can make that best in a parenchymal window. Go to the lung window.
In the video we can
You have a video also.
Here is the sir, cutoff is here and right side the bronchus.
Right? Where is the cutoff?
Sir,
Good. Where is the cutoff?
sir,
Like, since video is playing, it will be like difficult to show it on the this one, sir.
Okay, I got to know. I got the point what he's telling. I am asking him the location. Where is the cutoff happening? Which lobe or bronchus?
uh,
Is it happening in trachea?
no sir,
Is it happening at carina? Is it happening at right upper right main bronchus, left main bronchus, right upper lobe bronchus, right intermediate bronchus, right lower bronchus? Which one of the bronchus?
right main bronchus.
Yeah, okay. Show it once again. Hmm. Yeah, it is looking like. I would rather confirm it on an axial image. Go to the parenchymal lung window of axial images.
Sir,
Go back.
sir, lung actually is not yes, actually.
No, you had the first image which you showed was the parenchymal window, not this. Go back. Yeah, that. Yeah. Zoom this. Trace the trachea. Zoom. Yeah. Go up. So now you can see the trachea. You can see the bifurcation. And you localize any middle right main bronchus?
Right,
Show me where is the carina.
sir, here is
Yeah, the
yes,
next slide. It is more. Yeah, there is where the division is happening. In the next image, you can notice that there is left main bronchus which is patent and right main bronchus which is narrowed, right?
yes,
And come to the next image, the left main bronchus is still patent and the right main bronchus you can't visualize at all. Okay?
yes, sir.
Okay. Okay, good. There is bronchus cutoff. Okay. What is happening to the adjoining collapse? So now this becomes an active collapse or a passive collapse?
Uh, active collapse, sir.
Active collapse also. Okay, good. And there is pleural effusion as well. है ना?
Yes, yes, sir. Prediction is definitely
So
there.
there is bilateral pleural effusion and right main bronchus, probably an
Compression.
endobronchial lesion in the right main bronchus, which is causing why if the right main bronchus applies to all three lobes, right?
Yes, sir.
Why is it then local the features are more predominant in the right middle lobe and upper lobe?
Sir, maybe
Lower
the
lobe.
partial collapse is there.
Yeah,
Partial bronchial obstruction is there, and
correct. Maybe there is total obstruction which is there in the segments which is there in the bronchus supplying the middle and the lower lobe probably.
yes, sir.
Okay, than the upper lobe. Okay, can you go up once? Can you show the upper images? See here you can see some of the upper lobe segments are still aerated. Can you see the first images, the last,
Yes,
that one, the next, and the next? See, the upper lobe is still aerated, right? You can see the black areas, correct?
yes, they are also.
Hmm. Okay. What investigation you want to do now? Next, specific investigation. Prove the
Sir,
diagnosis.
sir, pleural fluid analysis can be done
Very good.
to, whether there is a malignant cell found or not. First of all, we have to do the whether it is amyloid activity. Then
Which
to
side you
do
would which side you would do? Both the sides, unilateral, bilateral.
sir, on the disease side, right side, I should like to do first.
Are you sure?
Sir, the one thing is there as the malignant is not known to me, so to confirm, I have to do the
Okay.
have
Any
to
difference of opinion from any other participants? before doing pleural fluid, can we go ahead with any other investigation?
Sir, bronchoscopy can be done.
Bronchoscopy.
Do you want to change, Dr. Kamal, now, or still
Bronchoscopy,
go ahead with pleural fluid?
bronchoscopy can be done.
Correct. In cases of active collapses, it is not very prudent to do a pleural fluid examination first. Okay, so if you now seen a bronchial cutoff where there is active collapse, okay, so and there is volume loss on the same side, so the collapse component is more than that of pleural effusion. Okay, and the anyways pleural fluid, you can't take pleural samples, the pleural samples. But in case of bronchoscopy, you can visualize the endobronchial lesion and you can take biopsies from the actual lesion which is causing the collapse. So I would, if I were to be the treating physician of this patient, I would have gone ahead with doing a checked bronchoscopy. I would specifically look into the right main bronchus and the left main bronchus, and I would expect a lesion there because CT is showing such a kind of a lesion. And I would go ahead and do a brush cytology, endobronchial biopsy from the lesion. Okay.
Okay.
At the end of the day, biopsy is always a better sample than cytology cells, right? Tissue always make a better diagnosis than cells.
Yes.
Making a cytological diagnosis is difficult than that of histological diagnosis. And pathologists would be more happy to make a diagnosis on biopsy than on cytology. Correct?
Yes.
So remember this, in a patient who is having more of active collapse and less component of a pleural effusion, because even in active collapses there might be minimal to moderate pleural effusion. In that cases, once active collapse or endobronchial pathology is suspected, always bronchoscopy. Okay. If these are not there, there is volume gain, there is shift to opposite side, contralateral side, then we could have gone ahead with pleural effusion. Which do you think is least invasive? Endobronchial biopsy or pleural fluid analysis?
The endobronchial biopsy is also.
No. Pleural fluid is less invasive because it is just inserting a needle from pleural cavity, right?
Yeah.
So invasive wise, pleural fluid would have been it would have been an easier technique. But in this scenario, in this specific situation, endobronchial biopsy would give a better diagnosis and an easier diagnosis, considering the semi-invasive nature of the procedure as well. Okay, you got the point, Kamal. If this were to be not an active collapse and had pleural effusion, your way of approach would have been better. Pleural fluid analysis would always been a better.
Got it.
But this patient has an active collapse.
Got it.
Okay, when patients have active collapse, you tap pleural fluid. The more pleural fluid you tap, the more it accumulates. Because endobronchial pathology, because of the endobronchial pathology, the lung is not allowed to expand. Okay.
Yeah. Okay. The thoracoscopy can be any option for
what? Come again?
Thoracoscopy.
Thoracoscopy also the same thing. You do pleural fluid analysis for 2 times, cytology. You don't get, you can go ahead with thoracoscopy. But this patient has a predominant mass which is compressing the main bronchus. So the pathology predominantly is in the hilar location. So I would do a biopsy, endoscopic biopsy first, then going ahead with pleural thoracoscopy. Okay.
Thank you.
You can do, but this is a case of active collapse. Active collapse needs endobronchial pathology treatment first.
Okay. Got it.
Just for benefit for everyone, sir, could you help us to understand how to differentiate active and passive collapse, and mechanism behind what is active and passive?
Okay. See, each segment is aerated with help of airways, right? Lung is like a sponge. it has to be aerated. Most of the lung is consisting of air. Correct?
Yes.
The borders of the alveoli is only the tissues. So if you remove air from the lung, it is like a compressed sponge. So the main thing where lung needs to be open and aerated, there has to be a patent airway. Okay, when the airway is blocked, the lung cannot aerate, and the air which is already present there gets absorbed, and what happens is the alveoli starts collapsing. When many such alveoli starts to collapse because of absent patent airway, it is called active collapse. Okay, got the point?
Okay.
Okay, what is passive collapse? Okay, passive collapse, air accumulates in pleura in case of pneumothorax, or water fluid accumulates in the pleura in case of pleural effusion. This air and fluid accumulates in pleura, which is more rigid structure, the chest wall or the lung? The chest wall
Lung.
is naturally the more rigid structure, right? Lung is collapsible. So the more the air and fluid accumulates in the pleura, it needs space. What does it easily push upon? The chest wall or the lung? It easily pushes upon the lung. So the pressure in the exterior of the lung, that is in case of pleura, compresses the lung and occupies the spaces which actually belongs to lung. This is passive collapse. Got the difference?
Got it.
The airway is patent in passive collapse, but there is pressure from the outside the lung compressing the alveoli, causing inability of the alveoli to keep itself aerated. Passive collapse. Whereas in an active collapse, there is no patent airway. There is no adequate aeration to the alveoli or the segments of the lobe. This is called an active collapse. Okay, what do you do in passive collapse? The treatment is removal of the air and fluid, as you do in cases of thoracocentesis or chest tube insertion in case of pneumothorax. But what do you do in case of active collapse? You maintain a patent airway. Okay, how do you maintain a patent airway? In this case, you do a accurate diagnosis, tissue diagnosis, give him chemotherapy, the mass shrinks. Even if that doesn't shrink, you can put a Y stent into the trachea and maintain the patent airway if the prognosis is good. So the diagnosis of active and passive collapse is very important because treatment is different. I hope I made it clear or gave some
Yes,
points
sir.
to you differentiating. Okay.
Definitely.
Main thing is patent airway, non-patent airway. Okay. So it basically tells which side you have to approach from the chest wall or from within the airway. In an active collapse, you go to the airways and remove whatever is plugging. It might be tumor, it might be blocked mucus plug, it might be blood, it might be respiratory secretions, it might be foreign body. Okay. But in a passive collapse, it could be blood from outside, pleural thorax, hemothorax, pneumothorax, or massive pleural effusion. One of these.
Got it.
Okay. Any other questions? You want to go know the further go into further details? We can even proceed. I think it is time also.
Sir, we can proceed.
Now, how likely is this to be tuberculosis? Could this be tuberculosis?
No.
What do you feel, Dr. Kamal?
No.
I'm sure that you know that tuberculosis can even cause endobronchial lesions.
Yes, sir.
Right?
Endocrine TB can be there. Yes.
Yeah, endobronchial TB can be there. So this could be endobronchial TB.
Sir, should be confirmed in the contrast.
How does contrast help? No, it doesn't. What do you look for in contrast?
Sorry, sir, not able to.
Okay, fine. Okay, I just wanted to know that when your differential is always tuberculosis, I don't want you people to send only for histopathological examination of the biopsy, because your differential is TB and even endobronchial tuberculosis can cause these lesions. I want you to send the tissues directly to the nucleic acid amplification test like Gene Expert MTB, which is there, which can diagnose TB endobronchially. You know, the endobronchial TB is a not a paucibacillary tuberculosis. It has very high bacterial load, correct?
Yes.
And it is very contagious. So if this were to be my patient, I would send the biopsy samples for histopathology. I would preserve these samples for future molecular analysis if this were to be a lung cancer. And I would send the saline, I would send the biopsy samples in saline for AFB and mycobacterial cultures. I would send the sample in saline for gene expert analysis. Okay. So it is not just doing biopsy, it is what you are suspecting and sending it for the right investigations to differentiate the differentials that you have.
Got it.
Okay.
Yes.
Okay. Do you want to do Montu or IGRA in this patient?
Montu can be done, but IGRA.
Anything can be done. Do you want to do or not? Or does it help you in differentiating things? What is the role of Montu in India?
The Montu maybe false positive can be there already. Maybe all the persons are maybe exposed previously or due to the vaccination.
Montu test is used for diagnosing what kind of tuberculosis? Active tuberculosis, latent tuberculosis.
Latent TB.
Okay. Do you think this is latent TB or active TB if it were to be a TB? Is this latent
Active TB?
This is active TB, right? So you people have to know that IGRA and Montu will have no role in diagnosis of active TB. Okay. It doesn't help in differentiating, but most commonly it is misused in India where it is endemic. So we shouldn't use, there is very poor sensitivity and specificity for Montu in diagnosing active tuberculosis. When patient has symptoms, you shouldn't do Montu. You should take history and try to prove the diagnosis that it is TB. Montu will have its sensitivity to differentiate only latent tuberculosis, that too with a poor specificity. Whereas IGRA will have certain higher specificity. Okay, so you shouldn't do Montu. Montu will have no role. Even Montu is negative in this patient, doesn't signify anything. Positive in this patient doesn't rule out or rule in anything. Okay. Okay, what else? Okay, Chetan was telling about something, trapped lung and entrapped lung. Are they both same?
No, sir, not same, sir.
Yeah, very good. What is the difference? Can you enlighten all of us?
Sir, entrapped lung is...
tell.
Yes, sir. Entrapped lung is due to the incomplete inexpansibility of the lung due to the visceral pleural fibrosis that doesn't allow to expand the lung.
Mm-hmm.
Trapped lung due to maybe due to poorly ventilating lungs due to any endobronchial obstruction or probably
Correct.
due to mostly due to endobronchial obstruction, sir. Trapped lung.
Others got the difference. Basically, it is kind of a active and a passive collapse. You call it in different names. Okay, how do you differentiate both?
Active and passive collapse, sir.
No, trapped and entrapped lung.
Sir, again by the diagnostic bronchoscopy, we'll have a look in the investigative wise.
Okay, diagnostic procedure of choice to differentiate both of these.
Bronchoscopy only, sir.
No. Anyone else? Okay. Have you heard of intrapleural manometry?
Yes, sir. Measuring the intrapleural pressure.
What is that has a role in differentiating these two entities? Okay. One you said is active, other one you said is passive. which will
Yes,
have
sir.
more negative pressures?
Sir, active will have more negative pressure.
Correct. So there will be more of suction pressures in active. So intrapleural manometry is one technique which can differentiate both of these. Okay.
Yes, sir.
Anything else? I think most of you are hungry. I am also hungry. Let's, if there is nothing, then we can wind up close.
Um,
I hope I was useful. At least
Definitely, sir. Class was very useful.
Dr. Kamal, was
Yes,
I
sir.
useful? I was not very irritative, right?
So thank you, sir, for your knowledge, sir, and for sharing your knowledge with us, sir. And we are enlightened with your knowledge, sir, and each and every point you discussed and the question you asked.
Okay. It is just a process of learning. It is not that I know things or you know things. Just interacting. Because you are in a course, we have also come out of it. You will be scrutinized more. Not that you know less or know more, but you will be in the other side, right? You will be as an examinee. So there'll be a lot of questions. They'll assess you. Just keep your history taking was good, and your approach was good. Try to analyze things because that is what people look at. Now you have come to postgraduate level where they expect a good history taking. Okay, but now you have to think before you ask every question and start to analyze where the symptom is arising from, what could be the localization. Once you do that for every symptom, then club all the symptoms and try to fit into a particular symptom. Take a good negative history, etiological history, and form a good differential diagnosis. Keep 1, 2, or maximum 3 as your best differential diagnosis, and keep in your back of your mind the other differentials also. If they ask you, then you tell. Oh, they'll get to know that okay, you have a wider differential. You'll have least chances of missing things, and make a map in your mind that which is point favoring your diagnosis, not favoring. If everything is favoring, you don't need investigations only, right? You can directly go ahead with treatment. So there are something which needs to differentiate it based on your investigation. Okay, and know about sensitivity, specificity, when you have to do particular investigation, what will it help through. Go that way. Okay, your history taking was good. Your analysis has to be much better. You have to analyze more before presenting. That is a period where you will be asked to sit before going to the examiner, where you have to think about what are the differentials, how to present it, what are the points favoring, negative, and form a plan. Okay.
Yes. Got it.
Okay,
Thank you.
good.
Thank you, sir. Thank you so much, sir.
Okay, right.
Thank you so much,
Thank you, sir.
Harshith, sir, for spending your time with us.
Okay, fine.
I learned from class and the discussion on even further management. I think very important as clinicians while taking care of patients.
Yes. And one more suggestion is, don't try to learn everything for your exams. Exams will go. Now my exams is gone. Now whatever stays in my brain is for my future patients, right? Take that as a primary motto than examination.
Yes,
Okay.
sir.
Okay.
Yes.
Try to examine patient in that way that you learn for your life than your exams. Exams is just a examination which you might pass or fail depending on the scenario, current day's performance, but something which you need to know for your future practice.
Thank you.
Okay. So these are my. So sorry, I made
Yes,
it
sir.
very long and probably boring too.
No, sir, it is very
Sir.
helpful, sir. It is very
Yes, sir.
helpful, sir. Very
Okay.
helpful session.
Fine. Okay, we can have future sessions as well if you people like.
Definitely, sir. We'll plan future sessions and we'll inform you, sir.
Fine.
Thank you so much, sir.
Thank you.
Thank you so much.
Thank you.
Thank you,
So
sir.
much.